Good evening, everyone. Thank you for joining the meeting this evening. We would like to remind everyone that the meeting is being recorded. Please contact the MHCC team with any technical issues. We sent an email last Friday with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of background noise coming from your line. You can also mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to speak to ensure that we have a range of perspectives. Please raise your hand by clicking the raise hand button under the reactions at the bottom of your screen to ask a question. Another option is to enter your question into the chat box. Before we begin the meeting, I would like to recognize the work group members who are attending the meeting today. Dr. DeGarala, Senator Lamb, Laura Russell, Dr. Rafi, Dr. Bernstein, Ms. Catherine Logren, Mr. Salentano, Dr. Khanna, Dr. Conway, Mr. William Henderson, Reverend William Johnson, is there anyone who I have missed who would like to introduce themselves at this time? Hearing none, I will now turn over the meeting to MHCC's Executive Director and Workgroup Chair, Mr. Ben Steffen, to make opening remarks.
Thank you, Anene, and I want to welcome all the workgroup members and note that we have about a half dozen staff folks on the line too. I want to say first off that we have a pretty ambitious agenda tonight. We're going to make one adjustment. I understand that Ken's son has a birthday, and in recognition of getting him out of here at a reasonable hour to celebrate with his family, we're going to move presentation 4 up in front of presentation 3. I don't think that it will cause too much problems in terms of flow of the meeting, but we want to get Ken to his birthday party, if at all possible, at a reasonable hour. While we've been away, the staff has been very busy examining experiences in other states, meeting with the MCOs to talk about opportunities for the Medicaid program to participate in the investment initiative here, all with the aim of meeting again with the work group, gathering your input, but with the moonshot goal of having a report to the legislature by December of this year, in which we lay out a plan for elevating primary care investment and measuring the success of that plan in the years ahead. So we're excited to tell you about the analysis work we've done, the meetings we've held, and get your input in particular in the last session, where we will be asking for work group members' comments on the key point of setting a primary care investment objective or target as part of the plan. So with those remarks, I'll pause very briefly for any questions or anything that I've missed on the part of that staff want to bring the work group's attention to. David, did I miss anything?
No, indeed. I think you covered it quite well. Thank you.
So as we said, we're going to move the order of the presentations around so we can accommodate Ken. This is work that we started several months ago, perfected it, and I think we have some good information that Ken's going to unfold for you tonight. So Ken, please go ahead.
Thank you. Good evening, everyone. Thanks, Ben, for that wonderful accommodation, and spending time with Nicholas later on. So this is the primary care investment model results, and we're looking at this at a little bit of a breakdown level First, we look at it at an aggregate level, but now we are going a little bit further, looking at it from a private payer, perspective. Next slide, please. So first of all, just to take us back, what we considered before we to develop these results, we considered a modular approach. We'll talk a little bit about that, to refresh your memory. And then we'll look at the narrow place of service again, which we had discussed before. And then this time, which is new, we are going to, examine the results by and then I'll like to call that module 0. I just like numbers, and then for module 1, we will look at the same breakdown by private payer, but by the behavioral health spending. And then module 2, we look at the OBGYN spending. Same thing as what we have before, but looking at these by payer. And then we take a quick look at the appendix. So next slide, please. So the modular approach were the methods that we used to accumulate these results. So as you remember back in I think it was in April, we considered 3 modules, right? So the work group wanted to measure core primary care services. Not only that, but have the option of also including the measurements of certain behavioral health services and OBGYN services. Now, this modular approach allows us to see the spending on in each category separately. And if we want to add them together, we can do so or keep them separated. But first, we consider the spending on a core set of primary care services. Now, in order to develop this code set to support our definition, we took a look at a code set that was developed by NICESCO, which is a group of New England states that came together and developed a standard for measuring primary care investment. Now, this standard was developed a few years ago, before the pandemic, as what Mary Jo had actually told us last time we were here. So what we did, we tweaked that NESCO definition, the NESCO definition, to fit our needs. And the first thing that we did was to expand the list of telehealth codes, and then added some remote patient monitoring codes, such as the primary care physician portion and other primary care services portions of those codes. Secondly, with regard to the taxonomy codes, we use the NESCO as a baseline. Also, we reflected the work group's interests in team-based care by adding some of the clinical nurse taxonomy codes. So for the behavioral health model, for this model, the work group wanted to separate behavioral health services that were provided in collaboration or integrated with primary care. So therefore, what we did, we used a basic set of outpatient behavioral health services and applied a taxonomy framework, which said that either the servicing taxonomy needed to be a primary care specialty, meaning those same core set of primary care provider specialties that were used to measure primary care, or if it was a behavioral health specialty in the servicing taxonomy, it needed to be a primary care taxonomy specialty in the billing taxonomy. Therefore, that billing taxonomy of primary care will depicts how we will link back to the behavioral health integration. Now, this was an approach that was similarly used in Colorado.
So Ken, can I interrupt to make sure everyone gets that? So for example, in a large primary care practice, the billing taxonomy code would be primary care, but if by chance That practice had a clinical social worker or a psychologist that was part of that practice and billing under the taxonomy, under the primary care practice taxonomy code. That would be counted. Is that, do I have that right?
That's correct. Yes. All right.
Go ahead.
All right. So for the OBGYN services, the work group wanted to include a broader set of OBGYN services, including prenatal care and deliveries, but not including the OBGYN specialists, but referring back to that same core set of primary care provider specialties. So for example, we are including in this module the services when a one is delivered by a family medicine physician, but not when that newborn is delivered by an OB. So on to the place of service. So the place of service code, we use two approaches. First, we look at no variation or no restriction, sorry, to the place of service code, meaning include all of the place of service codes. And then the second approach was to look at a more narrow approach, a narrow definition, in which we remove certain care settings such as retail clinics and urgent cares. Next slide, please. So in this slide, we look at the narrow place of service definition. So on the box on the left, depicts a distribution of frequencies by these top four place of service codes. So we can see that the provider office is at 82%, followed by the on-campus outpatient hospital at 6%. The urgent care facility, maybe it's at 6%, it says 5.9, that's pretty close, and then back up by the telehealth at 5.4, and then everything else is about 0.5% or just above 0.5%. So as I said just previously, that the narrow definition, exclude certain place of services like urgent cares facility and retail clinics. So therefore, the urgent care center here will not be included in the narrow definition, which brings me to the exhibit on the right. So the exhibit on the right shows all of these place of services, all 17 of them that are included in the narrow definition. But those highlighted place of services are the actually grunt of this narrow definition, as these highlighted place of services make up of 94% of these place of service codes, as depicted in the box on the left. Next slide, please. So now we're looking at the narrow definition, and it's the first time we're looking at spending breakdown by payer. Now, the payers that are included here, or carriers, they are Aetna, CareFirst, Cigna, United Healthcare, and other. Now, the other category is a really small category, which in my mind, I think it doesn't really have that credible data. It includes TPAs, and not the TPAs that are associated with CareFirst or the one that are associated with United Healthcare. Those are included in those respective insurance carriers. But the other include those TPAs and also State Farm insurance. State Farm insurance is not one of those traditional insurance companies. It only provides insurance to its employees. So it's not one of those, it's not like a CareFirst or Aetna or so forth. It only provide insurance to its employees. So when we look at, we look at the primary care spending as a percentage of total medical, just as what we had before. What we had before, we consider it in aggregate, that line that says private payers, that's what we showed last time. But now we are looking at a more drill down format where we show these results by payers from 2019 to 2021. So the first set of results that are presented here shows the primary care spending as a percentage of total medical. And we could see that there is not much variation across years or even across payers. It's pretty uniform. And also, and when we move to the right, the first result we see is that the primary care per member per month, spending result on a per member per month basis from 2019 through on, and then you go further to the right, we see that annualized result, which brings a per member per year result or a per capita result. If we look down below, we have the narrow definition, which, as we said, we included, we remove certain place of services such as retail health clinics, and also the urgent care centers. So we see with the same kind of format results here, we see it's very, very similar. There's not much daylight between whether you include all of the place of service codes or you have a narrow definition. These results are really close, right? And also, we could see as well, there is very little variation even across the payers as well. Same setup with the per member per month primary care spending, in the middle, and then move all the way over to the right, we see the annual per capita spending, which is the annualized per member per month results. Next slide, please. So this slide shows the same with the narrow definition, but we have a more of a, not a breakdown, but a drill down. We're not only looking at it by payer, but we behavioral health spending, and those services that have a behavioral health diagnosis in using the principal ICD-10 diagnosis code. So the reason why we want to show this is that because of module one have shown a very small, limited set of behavioral health results, and because that was, and I'll show in the next slide, that is based on an integrated experience claim. But this one, this includes those behavioral health services that are your basic 992 visits, that are performed for diagnosing anxiety. When a patient go to see his primary care, this is when I went to see him. I have my annual physical at my PCP this time around last month. He asked me, "Well, Ken, are you okay? Are you feeling well? Are you depressed? How is your mental state?" Those are that will bring out to say, well, oh my gosh, well, maybe I'm depressed or something like that. Those are what is included here in results are included on this slide and not in module one. Slide, please. So for module one, this is the behavioral health spending for a behavioral health CPTs with services provider if they are associated with that billing provider. These are a subset, includes a subset of codes. It's an integrated behavior experience claim. Now, these results will start very low initially and increase over time. Now, these does not include those basic 992 visits that I just talked about on the previous slide. So as you could see, the results in the same format where we see the primary care spending as a percentage of it's very small. When we look at the narrow as well, there's very little daylight between those results, whether you include all of the place of service codes or you look at the results are really close, and there's very little variation across years, well, somewhat, but very little variation across payers. So are the results that show those behavioral health spending. Now, these payments that are reported in module, we can see module 2 can be added to our definition I call module 0, if desired.
Can I ask a clarifying question?
Yes.
Go ahead, Dr. Khanna.
So the first question is, are these behavioral health codes that you're looking at, are those the primary reason the patient was there? And then the other question is, when you say behavioral health CPTs plus behavioral health serving provider, are you talking about the social workers that exist in primary care offices? What are we talking about here?
No, these are as I said before, these are those claims that have to be associated with a provider that have to be primary care.
Mm.
So just to get a finer point on that, so the taxonomy code of the billing practice has to be primary care, but the rendering provider, can that be a social worker?
Could be a social worker. Yes.
Yeah, I think that's
Yes.
what Dr. Khan.
Yeah, it could be a social worker, but the billing provider have to be a primary care provider.
Primary care. I see. Thank you.
So Ken, as you're looking at the narrow definition on slide 6 and module 1, why is it that in the narrow definition, it's a larger percentage of total spending than module 1? Can you differentiate that for us?
Okay, so in this spending, this includes all of those patients who care. It has a broader set of behavioral health spending, codes that, like any if any patient that goes to have a standard visit to your primary care and in conversation and consultation, you found out that you have a behavioral health issue, that will be reported here. Now in module 1, which this result is not included, that is a narrow subset, that is that have to be an integrated behavioral experience claim. So it's a very subset of the behavioral health codes.
Okay, all right, thank you. Any questions there? Is that clear to everyone?
I have one question. What line of business are you pulling the data from? Is this Medicare, Medicaid, commercial? Do you know?
This is private. This whole presentation is for the privately insured. It excludes Medicaid and Medicare.
Okay, so it's commercial then.
Yes.
Okay.
And Ken, we have one major payer. I think people know this, but we have one payer missing, Kaiser. And why is that?
Yes. So we have excluded Kaiser because we don't have the fee-for-service equivalents for the professional services. Because of the capitation model. Now, hopefully, we did have meetings with Kaiser, and they were able to provide those fee-for-service equivalents. So, but that information is not available until the 2022 data. So, as we look at these results and going forward, hopefully we'll have those results so that we could include Kaiser in this reporting as well.
Thank you.
Ken, this is Sally Alborn. Your private payers, is the definition, is that self-pay or privately paid? What is the definition of private payers?
A private payer, they have to be, it's like privately insured, right? It's when you compare, it is not, it is non-public. So you have Medicaid and Medicare, which are public payers, and these are just like the privately insured things like Care First and.
Oh, so is the line private payers an average, the
No.
bolded line?
The bolded line is all the private payers.
All the private payers added together, yes.
Oh, added together, okay,
Okay.
all right.
And there could be a beneficiary who has not met deductibles or has a sizable copay. This is what the private carrier pays. It does not include copays and deductibles. Do I have that right?
No, this includes, yes, this includes the patient portion.
Okay,
Because these are allowed amounts.
Okay.
Right? If we were just using reimbursement, which excludes the payment portion, which is we could say as plan paids, then that will only be what the insurance company pays, right? What is covered for that particular plan. But this includes the patient portion as well. These are allowed amounts.
Thank you for the clarification. And Matt has a question. Go ahead.
Thanks. Thank you, Ben. First, Ken, I highly object to you leaving early. No, I'm just kidding. You should go to your son's birthday. But do you have any indication, or did you get anybody to share trends in self-insured markets for these modules, or is it just the private market?
No, we do have self-insured here because we have the state and local governments, and also we have all of the self-insured non-ERISA accounts in this data, and also the self-insured ERISA plans that are reporting voluntarily as well.
Okay, so Sally Ann, for your benefit, when this group that it's not with the state employees and that self-insured marketplace, this is only 17% of the total insured lives. You can add state employees on top of that, which is the biggest self-insured group. But if you have private corporations like, Johns Hopkins being one of them, or Giant Foods, they're not going to be a part of, I think, this particular data set, just for context.
Yeah.
Right.
So
Because
sorry,
correct.
question so Johns Hopkins, if it has like Care First insurance, that would not be in here. Like
That's correct. It's self-insured, so it's not private commercial insurance.
If it's like the self-insured ERISA, which included about a third of the privately insured data is not included here, and also the federal employees are not included here as well, which those together make up about 44% of the privately insured population.
I mean, this data is very helpful, but it's a very small sliver of the insured lives in Maryland.
It is, but it's a good.
I want to clarify that. I think that we're throwing around percentages kind of carelessly here. So when Matt says 17%, I'll put him on the spot and ask him to identify the universe of covered lives that you're talking about there, because you're talking about Medicare, Medicaid, and the
No.
commercial market.
No, I'm just talking about, and I'm not Medicare and Medicaid. I'm talking about small group, large group, individual market.
Yeah, I think it's a bit larger than 17%, based on.
The MIA's covered lives report from last year is 17%.
Yeah, but remember, this is not coming through the MIA.
Right. Any more questions?
I think Dr. Bernstein put one in the chat asking if it's administered by private payers, is it still not included? So I'll let you field that, Ken. So like if CareFirst is the administrator, but it's self-funded.
Well, no, I mean, yeah, we do have TPAs here, right? You know, but the what is excluded here are the self-insured ERISA plans. So if a plan is have a self-insured, ERISA plans, those are not really included here because of the Gobey versus Liberty Mutual court case.
But Ken, to clarify that, Jeff's question though is, so when I was at CareFirst, one of my accounts was a major corporation. They were self-insured, but CareFirst paid their claims.
CareFirst is just a TPA in that fashion.
Right.
Yeah.
So, I mean, what's the distinction between?
Because CareFirst doesn't have the authority to report those claims. They belong to the employer.
Yes, they belong to the purchaser.
Okay, so it's a procedural issue as to why they're not included.
It's also a federal law issue, but yeah, you
Right,
get it.
yeah. It's
Wait, but I thought
procedural.
he said the TPA wasn't, it was the TPA wasn't, that's why I'm confused. So like if
Yeah.
first is the TPA for,
So,
Yeah.
Dr. Conway, if I could just clarify, so there are self-insured plan employers. ERISA protected self-insured employers are typically for-profit companies. Government is also oftentimes self-insured, as is the state of Maryland. They are not protected by ERISA. And as Matt noted, there a recent Supreme Court decision said that ERISA protected plans do not have to submit to APCDs, but government self-insured products typically do. The exception there is the federal employees, which recently concluded that they were more like ERISA protected self-insured plans than other government, and therefore they stopped submitting in 2018. Is that correct, Ken?
The spring of 2019.
Okay, so the last complete year was 2018.
Okay.
So the self-insured market is actually fragmented between ERISA plans and non-ERISA plans. They're all self-insured, but only the ERISA plans are protected by the 2016 Supreme Court decision that said you don't have to submit to state APCDs.
got it. So then just to go back to the example I was giving earlier, so for Hopkins, which uses CareFirst as a TPA, that would not be protected under ERISA because that is not for profit.
That I believe that the Hopkins data is not submitted by CareFirst, but we can confirm that. I'm not.
It would not be submitted
not
by
be.
CareFirst. It's
Okay.
not, the data doesn't belong to CareFirst as a TPA, it belongs to Hopkins. And the
Right.
state can't require them to submit that.
So in a similar like Montgomery County Public Schools, would that be included
Yes,
in
Yes.
TPA?
yes,
Okay,
because they will not be
Okay.
covered under the ERISA protection.
got it.
Okay, all right.
It-
It's complicated.
It's even more complicated than that, but let's just move on.
All right.
Gist of it.
Okay, guess is the next slide.
Wasn't that fun?
So the next slide is the OBGYN spending, same thing by payer. And these are OBGYN CPTs and for primary care provider payments, but they have to be, they are provided by a primary care provider. So for example, on this slide, you know, those services that when a newborn is delivered by say like by a family, you know, physicians, you know, will be included here. But if that newborn is delivered by a OB, you know, it would not be included here.
Okay.
Right.
Does this include midwives? Does this include midwives?
Would it will only include it will only include midwives.
We'll have to get back to you on that.
I have to get back to you on that one. Yeah.
Okay.
Can I ask why it wouldn't? Like, I understand it as the nurse practitioner, as the specialist, the OB doesn't count. So it seems like the midwife also wouldn't count in there the same way the OB doesn't. If it was a primary nurse practitioner, that's different. But if you're doing a midwife.
Yeah, if it have to be a primary care practitioner, you know, to be included those OB or GYN services. It's
Right.
not just the specialists would be
Okay.
excluded.
And Ben, if it's helpful to know, on our primary taxonomy codes, we did not include midwives as a primary care provider. They can be, as Ken noted, supplemental as long as they bill under the taxonomy code. But they are not listed here as a primary care taxonomy code provider.
Thanks, David.
Sure.
Very good, thanks, David. So with this result similar to the previous ones, they are very consistent across years or even across payers, very little variations, and very similar to the narrow versus when you don't have any restrictions as far as the dental services are concerned. You know, so then again, if this is needed to be, you know, which is the very first method as well.
And we didn't break this out by urban, rural, but in the feedback we've gotten from family medicine, you know, physicians, those that are providing GYN services and even OB services are largely physicians, family medicine physicians practicing in more rural parts of the state.
Mhm.
Go ahead, Ken.
Yes, okay. All right, next slide. Then next slide, please. So these are the list of codes that we talked about back in April. So these are the core set of primary care service CPTs, and they're listed here, all from immunizations all the way down to prostate cancer screening. Next slide, please. And then these are core set of primary care provider specialties, you know, all 21 of them, you know, that are listed here as well. And then the list of behavioral health services, or 41 of them here. Slides continue, additional 43 more. Behavioral health provider specialties, 9 categories here. And the OBGYN services of 34 codes. other 35 as well. These are just the data notes, as I said earlier, that Kaiser is excluded from those payers due to the capitation of the fee-for-service equivalents, but we are going to have that information in 2022 data.
So Ken, before we let you go to the birthday party, one final question. You know, what's your conclusion based on the analysis that you just presented?
Well, my conclusion is that there is when we look at the narrow versus no restriction on the place of service, because there's also not only that, but there is very little variation across the payers. And, you know, it seems to be really uniform, you know. So the thing is that if we use the narrow definition versus the all, you know, it's probably doesn't really matter that much because of those three categories. They're so large. Office is 82%. Then we have the on campus at 6%, and then even the telehealth at 5.4%. So the conclusion is that, you know, also the behavioral health services that are included when someone just goes for a regular checkup and there's a behavioral health diagnosis, that is quite substantial than if we look at the module 1, which is a subset of the behavioral health codes, and those are not included in that module as well.
Thank you. Before Ken leaves, any final questions? What I was struck by was it almost points for a hybrid threshold, because although the percentage of medical spend are pretty close together, although there was some sizable variation from year to year, which I attribute probably to COVID. If you actually looked at the dollars invested in primary care, they did show somewhat more dramatic differences, which would argue for some sort of benchmark or aspirational goal that takes into account both the percentage and an absolute dollar figure. Just throwing that out there for some comments. Okay. Any final last comments?
I think the only last thing I would say is that to look at this analysis, you know, using the reimbursement amount, meaning separate out the patient portion and to see what those results look like, I think could be very interesting.
Thank you. Okay. Moving on. Thank you. We'll dismiss you, Ken.
Thanks very much, everyone.
Party. Don't eat too much cake.
Thanks very much.
Come back to haunt you in the middle of the night. Now we're going to go back to presentation 3. Over the last month, we've had conversations with a number of states that are ahead of us in terms of setting a primary care investment target. And the conversations we had were, I thought, very useful. Different states are at different levels of commitment and different stages of progress in meeting their primary care targets. Melanie Cavalier is going to present the conclusions we had. We found in the 5 or 6 states 4 states we talked with over the last couple of weeks. So why don't you lead us off, Melanie?
Thank you, Ben, and good evening, everyone. So as Ben said, I'm going to provide some comparative data for select states on primary care investment strategies. Next slide, please. So as Ben also mentioned, staff convened virtual meetings with representatives from select states that have or are currently conducting studies to inform the development of primary care investment targets. These states included Colorado, Delaware, Oregon, Rhode Island, Vermont, and Virginia. The meetings took place in May and June. The Vermont and Virginia findings are not included in the slides because they were conducted Friday afternoon. So we sent the states a list of 12 multiple part questions in advance of the meetings. The questions were broken down into 22 categories for this presentation. The questions were designed to discuss how the states arrived at their approach to setting a primary care investment target and lessons learned from the progress that could inform our results. So these are information providing from the state representatives. So, some of them, may be a little bit different than things that you've heard or seen in the past. So next slide, please. So I'm now going to review the key takeaways from the meetings. Next slide. So the slides show the questions and then the key takeaways. So I'm going to combine the question with the takeaways, and I am going to ask that you hold your questions until the end, just because there's a lot and we might find that one gets answered by one of the ones that follow. So for items 1 to 4, the findings include the approach states took to establishing a primary care investment target was to perform a study and analyze the data prior to setting an investment target. States favored a voluntary approach over a required investment, and most states phase in annual increases. The predominant role stakeholders have in recommending policy related to primary care investment is engaging in a stakeholder work group or committee. Next slide, please. For items 5 to 8, the findings are in some states, the Health Insurance Commission directs the primary care investment program oversight. The program oversight includes conducting studies, making recommendations, and implementing annual investment changes if needed. The agency that directs the program has authority over the health insurance market. The policy levers available to the agency for primary care investment oversight are legislation and regulation. Next slide, please. So for items 9 to 12, the findings are Oregon requires all payers to make increased payments to primary care providers. In other states, only commercial payers are required to make a yearly increase. Most programs consider different investment levels by payer type. Some states allow exemptions from participation based on the number of covered members. Some states have standards related to how primary care providers can use additional investment funds, and sometimes they are fixed requirements. For example, in Rhode Island, payments must be utilized to support the development and maintenance of a care management function within the practice site. Next slide, please. So for items 13 to 16, the findings are the percent of commercially insured ERISA protected self-funded employers ranges from 10 to 50%. In most states, it has been difficult to engage employers in the primary care initiative, but some employers participate in state policy work groups. Oregon and Rhode Island required payers to make upfront investment payments to practices to build and sustain infrastructure capacity. Oregon created an attribution methodology and philosophical agreement, but it has not been universally adopted. In other states, payers use their own attribution methodologies. Next slide, please. So for 17 to 20, the findings are some state investment calculations include additional taxonomy codes such as OBGYN, place of service codes, and prescription drug costs. Delaware and Rhode Island require lower non-primary care cost growth to offset increased investments in primary care. Globally, programs consider an offset to generate savings to the total cost of care. From the Maryland model standpoint, an offset would be reasonable. Some states include non-fee-for-service primary care investments, such as health information technology incentives to providers, and other methods like investments in loan forgiveness for training physicians in the primary care spend algorithm. And some states use all payer claims databases to report the data. Next slide, please. So for items 21 to 22, The findings are the rationale for including psychiatry is to only include mental or behavioral health screening or when the service is provided as part of an integrated behavioral health arrangement. The rationale for including OBGYN is to measure services provided when the OBGYN is really acting as a primary care provider. Some states include place of service codes like urgent care or school-based care in the primary care definition. Next slide, please. So that concludes my presentation. The appendix contains more details related to the state's responses. And then if you just want to flip through them quickly so they can see. So each table has an abbreviated question and then what the response was from the state. And this is on there for all 22. And then if you can go to the very last slide. We did ask Colorado some very specific questions to their program, and those responses are contained here on the last slide. So I'm happy to answer any questions.
So, Melanie, I have one to, on a continuum, and maybe you haven't thought about this, what I was struck by in the sessions I attended, which I think were almost all of them, was that I guess the rigor of the enforcement differed quite a bit. Do you have any comments on that?
Yeah, it definitely, the rigor of the enforcement did differ quite a bit. In some states, Vermont is not included in there, but Vermont has a statewide ACO model. So really their investment is being embedded into their primary care model or their statewide ACO model that they offer. So there were definitely states like Rhode Island that was very specific and and very prescriptive about what needed to be done. And then there were other states where it was more of a suggestion. And then there's still states that aren't on here who were just obviously kind of studying and recommending and looking at it. So.
And what would parallel Maryland in some degrees would be an expectation that primary care investments would offset or reduce spending in other provider categories. Do you have any comments on that?
So I think in some ways the Vermont model where they have that integrated ACO where all the costs are considered together, so in Maryland, we also have a total cost of care model, right? So, we're looking at all the different components of it. I do also think Rhode Island, when they look at their expenses, they look at everyone's, they don't just look at primary care and how that's changing. So I think that's another model. I think we're probably closest to Vermont from the ones that I heard. I don't know if anyone else has any comments or thoughts on that particular question. Looks like Laura has a question.
Laura, go ahead.
Yeah, I just wanted to comment on this. So, when we talk about offset and I think the total cost of care model is very important, but HSCRC, only has the authority to regulate hospital rates. And so what are your thoughts on what might need to change in order to create an offset in terms of, perhaps MIA and other authority?
So Ben, did you want to take it or?
Go ahead, Melanie.
So, what some states like Rhode Island and Vermont do is, obviously the facility is the largest portion of the payment. So oftentimes the increase to primary care is then adjusted in some way, and that's reflected in more of the facility costs. But every component of it is looked at in these other states. So I don't know if this does any answer your question, Laura?
Yeah, I might add that, that in these other states where there have been offsets or attempts to recover or to assume that there's some substitution of primary care for other services, there's not overall rate setting in place. So I don't think that is a, across the board rate setting needs to be in place for some creative mechanisms to be put in place to allow some recoveries from elsewhere in the healthcare economy.
And if I could just pile on a moment, I think this is an important point because it's not a one-to-one and it doesn't happen. If you invest this year, you don't see an ROI on that same year. The investment the investment is made and the impact is on total cost of care. And part of what we would think that at least the other states have and that we probably have is it built into the plan is be able to say, as we move down the pathway a bit, we'll have categories of measuring to be able to assess that investment. So the targets become a way to be substantiated one way or the other.
Thank you, David. And we have two hands raised. I think Dr. Bernstein is first and then Dr. Khanna.
Question on a slightly different topic or component. I'm curious about what kind of feedback you got about attribution issues, rigor and consistency, especially because I wonder, especially if you're talking about non-fee-for-service payments being directed by attribution, but yet there may be inconsistencies in attribution that patients may be attributed to non-primary care locations, such as urgent care or specialists. Did you get a sense of the dilemmas or vagueness or how they handled those things? Because attribution in itself seems like a big issue.
Yeah, Ben, do you want me to fill this one as well?
Sure, you take the hard ones. I'll wait, take some easy.
So, I think that's an excellent question, but what I'll say is attribution is always a huge issue. The majority of states, it seemed to me, were letting the payers use their own algorithms. There were states, again, I'll bring up Vermont, because of the way they do their ACO model, they also use an attribution model for that, right? So their payments were directly related to that attribution model. Most of them, I guess it was a recommendation, like Nasesco, I believe, came up with an attribution algorithm that was a recommendation, but not a lot of the payers just really go with their own, if I'm honest. So.
Dr. Khanna.
I have an easy question. So I see that we're starting out at around 5 to 6% average, more like 5% on the dollar, including patient portion. So it seems to me like the only place to go is upwards. We really can't go below that. And I'm not quite clear on exactly how we think this total investment can actually increase in view of the fact that these numbers also include practices that are in the MDPCP model, I think. Although this total, the APCD doesn't really have Medicare data.
Yeah,
But-
so I don't think we have, if you're talking about the payments made under like an MDPCP that are non-claims based, I don't think we have those payments in there, correct, Ben?
Correct.
Where we are in the process of collecting them, but we don't have them for this time period.
So will this include the Care First model? Because the Care First does have a small payment, not anything great, but they elevate the rates when you do slightly better. So this would include that model, right?
Correct. Any payments that are additional
Claims-based.
payments are claims-based would be reflected. We do have a initiative that's just getting underway to collect non-claim-based payments from payers. They would be attributed to practices, not to individual patients. But that process is just getting underway. It would be, my thought that as we move forward with investment targets, we would want to figure out what the non-claim based payments contribute to any targets that were established. And to the point, keep in mind that this is all commercial.
That's what I was going to say, Ben, that their Medicare is not in here right now.
Medicare's
Yeah,
not
it's all
in.
commercial.
Yeah, we can actually calculate that for Medicare, but we don't have the non-claim based payments, the care management payments that typically are an ingredient in most advanced primary care models. Other questions? So any wrap-up conclusions you want to offer, Melanie?
So I'm sorry, before Dr. DeGurla just
Oh,
raised his hand.
Go ahead. Dr.
Or
DeGarella.
DeGurala, I think it's DeGurala.
Yeah, I'm embarrassed. I can't.
Yeah, Dugarala. Thank you.
DeGurala,
Yeah,
DeGurala.
Dugarala.
My apologies, sir.
No worries. I had a question about the voluntary target versus the required investment.
Mhm.
I see that Colorado and Oregon both had required investments. So I wanted to know, was there a lot of pushback from the private insurers? Do you know about that? And what exactly happens if they don't meet those targets?
So it's different in those two states. I think Rhode Island, they have authority to then adjust their rates during their rate setting process. They haven't done that because people have been meeting the targets there. For Oregon, even though it's required, it's a little softer. I think that you said Oregon, right? Yeah. So they don't really have a penalty per se. If the people don't meet, even though it's quote required, there's no actual penalty to the insurers for not meeting it.
Yeah, I think that what I came away with was that for the most part, these initiatives don't rest, with the exception of Rhode Island, in the office of the insurance administrator, which would have the most muscle to impose mandatory limits. That I was struck by even people who say it's mandatory. Their regulatory authority to enforce this was pretty limited. I think we probably would look to working closely with the MIA should we go forward with this to make it meaningful and fair.
Yeah, so I think, Ben, you asked me my takeaway. I think my main takeaway is that it seemed the path that we were on was in line with what a lot of the other states were doing. And I think it's really important to consider these lessons learned. And I think when we go into Mary Jo's presentation and we talk about the considerations, I think that you'll see that those are reflected in the next presentation, the considerations.
And seeing no further questions, David, you want to wrap this up and bring on Mary Jo? I know the two of you have worked very closely together.
Yeah, I think this was a great conversation. I won't say much other than some of the decision points that Mary Jo will talk us through is in line with what Melanie said. They're fairly consistent. And remember, just as you keep in mind, as we go forward into next year, we're really trying to say we have a plan, and the plan can change. It is not cast in stone. It's a plan is just that. So we think that the feedback that you all have provided thus far and what you'll hear tonight helps guide a plan. And we believe that it will grow and change. But year one is just implementing plan. So Mary Jo, take it away.
All right, thanks, David. Good evening, everyone. So what we're going to focus on in this part of this evening's discussion are 4 considerations when putting forward a target. And so I'll give you some trade-offs, and then I'll tell you what tends to work best based on our experience in other places. So if you go to the next slide. All right, so the first consideration is voluntary target or required increase. So most states seeking to increase primary care investment begin with a target. Over time, some of them require payers to spend a defined percentage of total medical expense on primary care. So, for example, your neighbor, Delaware, they began with a requirement of, with a target, a voluntary target of 12%. And then they moved to required levels of investment that are sort of stair-stepped over time. There are some advantages to a voluntary target and some advantages to required investment. There's also drawbacks to each. So when we think about advantages of the voluntary target, it engages people, right? It's a collaborative process. It inspires a shared commitment, and it's less likely to hasten or sort of speed up overall cost growth because payers can adjust the pace of increased primary care spending. A drawback, though, is that honestly, it tends to result in slower progress in reaching the primary care spending goals. So on the required investment side, the benefit is sort of the flip side of that. It's more likely to result in achieving increased primary care investment, but it's also more likely to increase costs. So as I mentioned, what we tend to see that works best in most states is to begin with a voluntary target, to get some experience sort of under your belt, to see normal year-to-year variation in spending, both within a payer group and across payer types, and then to consider whether or not you want to set some sort of required level of investment. Any questions on that one before I go to the next? All right, let's go to the next consideration. Okay, so the second consideration is whether to have a single target or a target for each payer type. So when I talk about payer types here, I'm talking about like commercial versus Medicaid versus Medicare, not Care First versus United or Cigna, but rather the types of payers. In the advantages column, a single target is easier to communicate. In the drawbacks column, it may not recognize differences across populations. So for example, a Medicaid population uses services differently, the benefit design is different, the needs are different, the age distribution of the population is typically different than what we see in a commercial population. A target for each payer type recognizes these differences in populations and also recognizes that even sort of the covered services, sort of what makes up the denominator, is different as well. However, it can be a little bit confusing. You have to explain it well, and it may raise more questions about the methodology and the fairness of different targets. I will say that most states that have a requirement out there are not doing a requirement across multiple payer types. So there's 4 states with a requirement. So Colorado, Rhode Island, Delaware, actually 5 states now because Oklahoma also, Delaware and Colorado and Oklahoma. Oklahoma is just for Medicaid. Rhode Island, Colorado and Delaware are just for commercial. Oregon is the only one sort of doing multiple payer types. And so I think that what we're finding is that when we are looking at multiple payer types, for example, the data coming out of Oregon, we see a ton of differences, big differences in primary care spending by payer type. And so I wonder if they were to do it again, they might actually decide, let's do a different payer, let's do a different target for each payer type. I'm going to go to the next slide and talk through this one because, Laura, go ahead.
Laura,
Sorry.
you have a question?
Yeah, Mary Jo, thank you. So my consideration here that I'd like to get some comments on is in Maryland, our model is all payer in nature. So what are the implications if we were to set a single target by payer?
And so, Laura, when you say by payer, just to clarify, do you mean by like commercial versus Medicaid, or do you mean a different target for Care First versus United? And I just throw those 2 names out there because they came to mind. There's a lot of great payers out there.
Yeah, I mean, I'm not as familiar with what other states are doing commercial wise versus Medicaid and Medicare, but my initial reaction to this is if we were to perhaps set different investment or expectations by payer, then how does that, affect the total cost of care and our all payer target?
Yeah, that's a great question, Laura. And I think that if you go to the next slide, I think that we can sort of address that a little bit. So the next slide talks about absolute improvement, which is setting a single number like 10% or 12%, or relative improvement, which is sort of increasing a percentage amount each year. And I apologize if you can hear that ambulance in the background, but so 1% a year, for example, or 1.5% a year increase. And that's an increase as a percent of total cost of care, not just a 1% increase. So essentially, if you're starting now, let's say 5.5%, you'd go to 7% in a future year. This sort of helps get around, perhaps in some cases, the need to have different targets for each payer type. If you set a relative improvement target and have everyone increase off of where their current baseline is, rather than expecting everyone to go to 10 or 12% in a specific period of time, you're able to sort of meet different payers where they're at. And then you can define sort of an eventual ceiling that could be potentially consistent across all payer types, like that 10 or 12%. Tricia.
I think I'm trying to maybe get at the same issue, but I guess when, if you don't have a corresponding savings target on the commercial side, aren't you just increasing the costs in premiums for these investment targets to the consumer? Doesn't just get passed on to consumer in terms of higher premium amounts unless there's a savings target?
I think that that's really the benefit of starting off with that voluntary target, right? Because then the payers are able to stair step those investment increases in ways that do not increase total cost of care more quickly than it would have otherwise increased. So starting with that voluntary investment target, allowing the payers to hopefully find some efficiencies and be able to transfer some spending to primary care, and then determining whether or not a requirement is necessary down the road.
Yeah, to be clear, Mary Jo, if we're talking about targets for commercial payers and Medicaid MCOs, there would be a significant gap starting out between the primary care share from Medicaid MCOs and the commercial market. That's what we're seeing in Maryland, and I would expect that's what's seen elsewhere as well. That the MCO share of primary care spending is typically quite a bit higher.
That's right. And I think that that's why it's important to sort of, as I say here, define an eventual ceiling, right? So you may have some payers within Medicaid, or, we didn't see any today within commercial that would likely be at that eventual ceiling, but you may have some payers in Medicaid that are already at the ceiling. We just, we don't have that data available to us today. So I think that this sort of approach of starting with a voluntary target, having this sort of relative improvement approach so that you're meeting each payer where they're at, and then having an eventual ceiling where you say, you know what, for now, we think this is a good starting place. And if we need to increase that ceiling later, we will. It allows you to meet current payers where they're at, increase primary care investment over time, and study the issue a little bit before any requirements were to go into place.
And just to Mary Jo's point, there is an element of measuring progress. And I think, Tricia, you're wanting to get a sense of, what that return is. And I think we're hearing Laura say the same thing. And there'll be opportunities to look at that and compare it to the investment, and then to step back and say, how do we make more definitive adjustments as necessary? And this incremental approach is critical to doing that.
Since we don't have any of our primary care advocates speaking, or they're not present today, I would note that there is a body of evidence, not overwhelming, but some that greater investments in primary care do, by their very nature, offset total total spending. But we've struggled in some cases to prove that in the MDPCP program. It's evidence is going in the right direction, but the reality versus the hypothesis versus the theory sometimes are a little bit misaligned. But I think we should note that primary care advocates would say getting the share right is going to, by nature, put you in a better position on total cost of care. I don't know if Chad wants to chime in here or William, but I'll leave it open before I know that Sally Ann has her hand raised as well.
Thank you, Ben. My question just was, in terms of particularly Medicaid, MCOs, and the fact that we have an all-payer system for our hospitals, how would, and Tricia's point about getting savings to offset the increased spend on primary care, when we can't negotiate rates and things like that, how, where is there some thought as to what that alignment would be, and where the savings would come from?
Ben, do you want me to take that one, or do you want to take that one?
Sure, go ahead, Mary Jo. I'll play a batter.
All right.
On that.
Sounds good. Sounds good.
You have the cross-state experience. What have they found? That's what I'm kind of looking for from you.
Sure.
Yeah, that would help. Yeah, great.
Absolutely. So if you look at Rhode Island and Delaware, they are using sort of restrictions on hospital price growth as a way to fund increased primary care investment or finance it. Your system's different, right? You have set rates, and so that is not as much of an opportunity. However, your system's also different in other ways. You also have, I think, a strong foundation of primary care transformation that is stronger than in some of the other states that have moved in this direction. And so, being able to leverage that, to Ben's point, what we find is that, yes, over time, increases in primary care investments pay off. But the key is over time. It doesn't happen overnight. And so that's why having these stair-step increases, having that strong foundation in primary care transformation that already is occurring in Maryland through MDPCP and sort of the history of efforts, I think really positions you well. I think the other point is, what we're not saying here is that the investment should increase from 5.5% to 10% in a year. What we're talking about is a gradual relative improvement target. So nothing, sort of a voluntary target that asks payers to gradually move more of their total healthcare dollar to primary care, where we know that there are benefits over time, benefits in quality, benefits in health equity, and benefits in affordability.
Yeah, and that's why, to me, the kind of incremental stair-step approach seems particularly appealing, given where we are with the total cost of care model, that it doesn't mean a great leap forward, but incremental and transitional progress.
That's right.
Go ahead, Mary Jo.
Sure. So just sort of putting a little bit more explanation to these ideas of absolute improvement versus relative improvement. So as I mentioned, some states put forward a goal of absolute improvement, like 12%. Other states put forward a goal of relative improvement or incremental increases in primary care investment. This is where Colorado is right now. This is honestly where Rhode Island started. They had an incremental increase for many years before settling on a defined absolute percentage. Delaware is sort of mixing these two models. They're doing a stair-step approach. It's 1.5% a year for several years until reaching that eventual ceiling. So the absolute improvement target is sort of aspirational sometimes. It sets a vision for the future. I'll tell you, it's rarely met as quickly as hoped. And one of the real challenges is that there's less guidance on how to operationalize it. So essentially, you tell a group of stakeholders, okay, we want primary care spending to be 12% of total medical expense. Well, what does that even mean? How do we get there? How am I supposed to really accomplish that? The benefit of a relative improvement target is that, to my point earlier, it acknowledges that care delivery transformation takes time. You're sort of gradually increasing the investment in primary care, and on a parallel track, supporting primary care providers in thinking about how those dollars can best be used. Another benefit to primary care practices is that it's more predictable increases in revenue and more predictable sort of across payers. A drawback is that sometimes saying 1% a year feels a little less inspiring than, saying 12% or 10%. I think that where we see the most success is when states combined these two approaches to let everyone succeed at a reasonable pace and yet still set an eventual ceiling to let everyone know that, the increases don't have to occur forever. I'll stop there and see if we have any questions. William Henderson.
So I just wanted to, I didn't get off mute early enough for the previous conversation. So this is really about the previous conversation. I just wanted to add on MDPCP. I think the analysis we have done shows that MDPCP is saving money. It isn't offsetting the investment, but it is having an impact on costs. And then this question of, the time, as David said, that it takes to get that investment, and maybe it's a matter of time, or maybe the investment is slightly set wrong. But it is definitely, I think all our data does show that it is having an impact on total cost of care, just not enough to offset the additional fees.
Yeah.
I'd also add on a different point, it is actually easier for Maryland, and I'm not advocating for this or taking any position on this, but practically speaking, Maryland can fund a primary care investment through an adjustment hospital rates a lot more easily than any other state could. And there's even a model, right, in terms of something like the prompt pay discount, right, where commercial payers can earn a prompt pay discount on their hospital bill by providing upfront funding to hospitals. You could theoretically use a mechanism like that to say, if a commercial payer achieves a certain level of primary care investment, they earn some small discount on the hospital rates, which then sort of shares the cost of the investment between the hospitals and the payers. So definitely not advocating for that or against it, but did want to throw it out there that I think Maryland has some flexibility in this area that probably doesn't exist in other states.
Thanks, William. Chad?
Thanks, Ben. Mary Jo, I was just wondering whether you've seen any designs out there in other states where they incentivize or reward payers to move faster in terms of the investment. So, instead of, let's say, if the increase was supposed to be 5 percentage points, doing it in 3 years versus 5 years?
No, but that's a really interesting idea. I haven't seen that yet. I will say that one thing I do see quite a bit of is sort of the power of transparency and stakeholder engagement. So when you have reporting by payer and you have groups of stakeholders like yourselves all seeing transparent information on the progress, that does put pressure on payers to move more quickly.
And Mary Jo, we might want to keep moving along.
Yeah.
Getting
Sure.
short on time.
We have about 5 minutes more here, so.
All right, we just have one more consideration. It's the simplest one, so that's good. So the last one is whether or not to report information as a percent of total cost of care or report per member per month amount. Most states set goals for primary care investment and define the goal as a percent of total medical expense, like 10% or 12%, 11%. Behind the scenes, though, it's really helpful to understand what that percentage translates to as a per member per month amount. So here's why. So it's sort of easier to understand sort of the budget that is available to primary care spending when you're thinking about it in terms of actual dollars versus just a percent of total medical expense. But there are some advantages to the total medical expense calculation or sort of framework, and that's why I think it's used so often. So it is consistent with other states and national approaches. So basically one person started doing it, so then kind of everybody started doing it. And it tries to communicate that the increased spending on primary care should reallocate existing spending rather than increase total spending. I think one important drawback is that it does not recognize differences in total cost of care across states. So some states are higher cost than other states. For example, if we look at the difference between Oregon and Delaware, the total cost of care in those two states is dramatically different. So 10% of it in one state is not equal to 10% of it in the other. Some advantages of the per member per month amount. It's easier to reflect the cost of achieving primary care goals. Like we can actually budget out how much does it take to implement these capabilities in a primary care office. It's also more consistent with how payers typically measure healthcare costs. So they're used to reporting a per member per month amount. But the drawback is that it doesn't really resonate with other stakeholders. You know, they're not sort of used to, you don't talk to a consumer and say, what's your per member per month healthcare spending? And even providers typically think of spending in terms of the cost of a visit or a specific service. So with all that in mind, we recommend Maryland continue sort of reporting both data points so that they can continue to understand what's the percent total medical expense and also what's that translates to as a per member per month amount. And that's all I have, Ben.
Yeah, it does strike me that that simply presenting the target as percent of total cost of care does allow, you know, potentially some payers to play games with their total medical spend and you know, reduce spending in some needed area to elevate primary care, but actually not show meaningful progress. So I'd argue for a hybrid approach too, that you do need to show primary care spending as a percent of total cost, but you also want to look at the per member per month amount to make sure there's not something really strange going on. Other thoughts? So we have a couple minutes. Can we go through go back to consideration one? We'll kind of do a rapid fire discussion here in terms of the voluntary or required increase. Do we have any additional comments now that we've walked through all four considerations?
Dr. Bernstein has his hand up. Ben.
Yes, go ahead, Dr. Bernstein.
That was exactly the location of my question. It's not intuitively obvious to me as to why required investment is thought to more likely increase overall costs. And it's not intuitively obvious about what increases costs anyway when you look at horizon or confounding variables. So I'm curious as to where that comes from and why
Sure.
that conclusion was made.
Yes, sure. So the reason that conclusion was made is that with a voluntary target, if you can't find savings elsewhere, you don't necessarily have to increase your primary care investment. You can just keep going on as you are. But with a required investment, even if you can't find savings somewhere else, you still have to meet the investment requirement. And so if that means that premiums go up, then theoretically that means premiums go up.
I guess I'd fall in the category of primary care advocate who would say that it's not so much what you forecast, but what the result is in the long run. And I'm not sure those line up.
Point taken. Seeing no additional questions here, let's move to consideration 2. Single target or a target for each payer type. Anyone want to weigh in here as we wrap up our meeting for today?
Ben, this is Jill. I was just going to ask, you know, some of this may depend a little bit on whether Medicaid is willing to lead, as it looks like they were leading in other states potentially, right? There were states focusing on Medicaid in particular to try to increase the spend, whereas other places are turning to commercial more for that. But that is something that, you know, state Medicaid could make a choice that they want to sort of put the foot forward first and demonstrate for other payers. So to me, part of it would be, you know, a question for what the state Medicaid program could do. But otherwise, I would think that it would be important maybe to have fairly consistent expectations across all types to avoid maybe, you know, some types of insurance feeling like, you know, kind of picked on, if you will, especially if the state wasn't able to kind of match what they were doing in other sectors. That's just it's not exactly a question. It's sort of a question. What do you think about it? I guess those of you who are in the state.
Tricia, do you want to weigh in first, or do you want to?
No, I mean, I'm happy. I mean, I think everyone knows in this administration, this is a priority of ours in terms of primary care investment and alignment. You know, I think, so again, it does require money, right? So we, and an investment, so that is still to be determined. The question I have, Mary Jo, as you kind of think about this, right? You know, you really do need to make sure, even if we're comparing across commercial and Medicaid and Medicare, there's different benefit packages. I mean, so, you know, Medicaid generally covers a lot more in terms of the different provider networks and services. And so that's probably a little bit that needs to kind of be considered in terms of where our target should be. You know, so, you know, as Medicaid gets pushed and pushed and wants to cover different peer recovery specialists, things that traditionally aren't covered in the commercial space, you know, we do need to recognize that we are investing in other types of providers that aren't necessarily covered by commercial carriers.
Tricia, I think that's a really good point. And I find that it's most important to do that work in sort of the denominator. So trying to get to a more similar comparison of the total spending buckets. Because you're right, there's a lot of spending on different types of services, long-term services and supports, other things that Medicaid does that commercial payers just don't do. It's not part of their benefits package. It's not part of their provider network. And so if the state were to go into the direction of having a single target, then it would be important, I think, to make sure that there's as much consistency as possible in sort of how you're measuring the denominator and the numerator across payer types, which may mean that certain Medicaid expenses are not included in that denominator, right? Because it's just sort of not fair, so to speak.
Yeah. Even if you were to, you know, to true up the denominators, I think the only way to approach, if you had a single target, would be to focus on relative increases.
Right. Yes. And so yes, I agree. And that sort of brings you to the next one.
Yep. So this is Kathleen. The other consideration is, unlike the commercial market, Medicaid has carve-out services away from the MCOs. And it would make it difficult, I think, to include those in anything that you're measuring the MCOs for. You know, behavioral health, long-term care, dental are all carved out from the MCO program.
Yeah, and certainly dental and to long-term care to a certain extent are not benefits that are typically wrapped into a commercial product.
Right.
But I hear you. I understand what you're saying, Kathleen. Let's jump to number 3. This is going to be a bumpy ride, the last 2, but I want to get you out of here within the next few minutes. But I want to be sure everyone who wants to weigh in can. And this is I kind of jumped this consideration a moment ago. Absolute improvement, relative, or both. Anybody have additional perspectives on this? And keep in mind, the record's going to be kept open for a while on these considerations. We're not taking this as final today. Sally Ann, are you trying to?
Well, actually, I was going back a step. In addition to Medicaid and the MCOs providing certain benefits that the commercials don't provide, you know, part of what we do and have done for years, and as part of getting our patients, our members to primary care, is some of the social supports. I'm not going into housing or some of the more advanced supports that are being provided today, but simple things like transportation, childcare, some that actually result in the patient being able to participate. And I'm concerned that as we talk about what we're spending and increases on primary care, that there isn't at least some nod to the different populations. So I kind of, for consideration number 2, you know, like to think maybe more of a hybrid method. And just wonder if you know, Mary Jo can comment on that, because, you know, right now, by and large, those costs of getting people even into primary care at the most fundamental level aren't included.
That's a great point, Sally Ann, and I think that that's another potential difference, right, between or across payer types. And I will say that in other states where there's a little bit farther along in non-fee-for-service data collection, one of the areas of non-fee-for-service payments that can be collected is if there's any supplemental payment made to a provider regarding social supports. And so as this work advances and in the future, as you think about the types of non-claims payments that you'd want to collect, that could be one that could be collected as well. But again, I think it sort of points to the need to potentially have those different targets for different payer types. And I think, you know, it's just another consideration. I think that if you look at this piece here, you know, where we have the absolute improvement versus the relative improvement. If you looked at the Medicaid data versus the commercial data today, you know, as Ben mentioned, Medicaid spending as a percent of total spending is higher. Medicaid spending on primary care as a percent of total spending is higher. What you might think about doing is having sort of a relative improvement target that asks, you know, all payers to increase 1% a year until reaching some sort of defined ceiling. And it's likely that some Medicaid MCOs will get there faster or may already be there, particularly as we take, you know, into consideration some of those definitional differences and sort of creating a more uniform definition. Another approach would be to, you know, seek the same sort of relative improvement across payer types, but have a different ceiling for each payer type. That could be another approach that you could take.
So I hate to raise a new issue so late in the day, but and maybe you covered it obliquely and I missed it, but are any states looking at how payments to address the social determinants of health are defined within a primary care spending target?
Yes. So there are several states that are sort of including this. So for example, in Delaware, payments to support community health workers, payments to support social needs screening. All of those payments are included as part of primary care investment when they're made to a primary care provider or care team or organization.
Okay. Thank you. That's helpful. I think you would get different perspectives among primary care providers here in the state of whether that's truly primary care. Certainly important, but does it really constitute primary care? Would be an interesting debate to have, but not one at 6:30 on a Wednesday night.
We'll parking lot that one.
Yes, I think it's important to consider that further. Let's go to number 4, and then David, are you going to take us to the true parking lot, or?
Yeah, I'm ready.
Okay, all right, just teeing you up. Again, I think this is a question that does entail some thought. Percent of total cost of care or per member per month. Any final thoughts that people want to offer before we conclude for the night? Dr. Khanna, do you have your hand raised? No, that's my hand. Go ahead.
It's raised in bye-bye. It's late, Ben.
Okay. All right. I understand. I get the message. So David, why don't you, first off, the record for these 4 considerations is going to remain open. I'll let a higher authority say how long, but for some time, I'd like to say through the end of this month, which is a week from I think Friday. We'd like to get more comments if you want to offer them. And David, tell me the next steps, and we'll let everyone go 10 minutes, 15 minutes late.
Yeah, so I would just note that, remember, keep in mind as you're thinking about any additional comments here, the plan is high level. Over the next year, we'll drill down, and if there are need to make modifications, there's plenty of opportunities. This isn't our last shot, our first and only shot. I think Ben's point is a good one, that as we're thinking of drafting this plan to submit, getting more ideas is always helpful, but it is not a fait accompli at the end of the month. So just keep that in mind. We are moving forward and trying to put together a draft for later this summer. Our next meeting is planned for August 24th. It would be super if we could have a good construct by then to share with you. That would be our hope. The feedback is great, so we appreciate it. I think we're not, as staff to the executive director, I don't think we're surprised at anything we've heard tonight in terms of the primary care investment goals and how they're, a direction to lean. But I just want to be careful that we don't paint these as absolutes, as rather it's more of a plan. So with that, Melanie, do you want to talk about when the summary and the documentation from the discussion with the recording will be made available?
Yeah, so all the presentations are up on the website, and the summary will be up there in 5 business days. We'll post the meeting summary. The recording usually takes probably 3 to 4 business days, but that will also be up there within 5 business days as well.
And it was a great conversation, and thank you all, and I'll turn it back to the executive director.
Thank you all. I want to again thank the staff. This takes an enormous amount of work in addition to what everyone else is doing here, and I don't want to recite what the Center for Health Information Technology and Advanced Care Delivery has taken on, but it's an enormous amount of work, just as other centers have multi-dimensional topics they're wrestling with today. So I want to thank them and recognize their enthusiasm and commitment to getting this done and meeting the directions from the the sponsor and the legislature, who I'm glad to see, also attended tonight. Really grateful that he attended and heard some of the feedback. So thank you all and have a great 4th. We will keep the record open on these considerations or any other thoughts you have through the end of the month. So thank you and have a good evening.
Thanks, everyone.